Hello, everybody. It's a pleasure and a privilege to be here. We'll go ahead and present the slides, and then we will go ahead and proceed with the case presentation that you have ready. So, with regards to the objectives, I would want you to be able to discuss the clinical signs and symptoms of dementia, and be able to differentiate that from depression and delirium. We would also want to discuss, the behavioral disturbances in dementia, and would like you to at least be able to list 3 types of these behavioral disturbances that you commonly see. And then towards the end of the presentation, I would want to discuss some of the legal and ethical issues that are related to patients who have dementia and that you might encounter in your practice. All right, so as we all know that the US is, among many other countries, is aging. We currently have about 5.4 million US citizens with diagnosis of dementia. And that number actually is expected to at least double by 2050. Okay, so we're looking at more than 12 million patients with dementia in the US. And a big majority of these patients actually is age 85 and above. So we're dealing with an old population. So before we talk about dementia, I would like to discuss normal aging. So only 5% of people who are 65 and above carry the diagnosis of dementia. So not all old people would have the disease, and actually it's abnormal for anyone to have dementia. So it's not a normal thing. It's more common as we get older, for sure, but it's never a quote unquote, like a normal phenomena. So what does happen as we get older in terms of cognition? So it would be expected that older people would complain of some memory complaints, that they are like a little bit forgetful, like here and there. But typically, like that forgetfulness, does not interfere, like with their ability to function. As we got older, we might forget, like where we left, like our keys or our phone. But then, we think about it for, like for a few seconds, and, we'd be able to find the phone, or we can ask for help. Okay, so these subjective memory complaints are typically annoying, but not disabling. It's also common for older folks who do not have dementia to complain of or to have some name retrieval problems, meaning I would meet you, and then, I'll meet you again in a week or so, and might be kind of like forgetful of, like of your name. But then with prompting, like most people would be able to retrieve that. I know some of us, suffer from that, like right now. But it's probably due to, to the lot of input, that we receive. And there's also some, like little bit of difficulties in recalling, like detailed events. So we might be able to basically recall, general events, but when it comes to description, we might have a little bit of a problem describing the details of what happened. Okay, so all of that is normal, quote unquote, and expected. Okay, but that does not mean, that someone would have dementia. So what conditions are not dementia? Again, we talked about, like age-related cognitive decline, where we have mild memory problems. Depression at times, can look like dementia. So when patients or people, like got depressed, one of the symptoms, that can appear is short-term memory loss. Okay, so people would have decreased ability to remember things. especially things, that occurred in the recent past, that they might have difficulty telling, like what happened yesterday or what they had for breakfast or who visited them, like last night. And that can be very much, related to depression. So when you treat, the depressive symptoms, that memory, like tend to improve. Delirium is another big one. And it's acute, like confusion, that occur typically in relation to a medical disease or a medical problem. So let's say, grandma or grandpa, they are doing well, and all of a sudden, grandma woke up this morning and she's very confused, she's altered. She doesn't know where she is, and she does not know what the date is. Okay, so it's an acute change. So typically that is not dementia, right? Because it happened, like very acutely. Dementia tend to happen, like gradually for a period of, like months and even years. So that condition is typically called delirium, and is due to a medical condition. One of the most common medical conditions that would cause delirium could be a urinary tract infection, something like constipation or pneumonia. Anything of that sort, can actually cause, like delirium. And yes, I get, like few laughs here about, constipation. Constipation can be extremely severe, like in the elderly, and can cause, like bowel obstruction, and like precipitate, like that acute, like confusion, like in mental state. So yes, things, that are, usually very common, we don't typically, like think about, but can definitely, like precipitate, like an acute confusional state. And we often actually, even as providers, like miss that because we don't, like often think about it. All right, here's an overview of brain anatomy. So in the red area in the front, that is, the frontal lobe, and that is responsible for intelligence, judgment, and behavior. So people or patients who suffer from, like a traumatic brain injury, or have, a dementia that is affecting, like their frontal lobe, they might, start experiencing, personality problems and, and disinhibition. A typical example would be, you have a 60-year-old, like, for example, professor at UNM walking on campus, and, newly diagnosed, let's say, with frontotemporal dementia, and then, like you would see him, taking his pants off and, like peeing in public. Okay, so it's very atypical of, like of him to do that, and then can be, like a sign and symptom of, like of a dementia. So it's very disinhibited. Or hypersexual behaviors, that sometimes, like occur, inappropriate, like touching, or, groping strangers. Okay. The green area, and that is the temporal lobe, and that is responsible for memory. So any impairment, like in that area of the brain, can cause memory loss. And typically we start with short-term memory loss, and then with severe cases of dementia, long-term memory loss is obtained. And that purple, area, that is the parietal lobe, and that is the region of the brain that is responsible for language. We typically find with patients with dementia, especially in the moderate stages, where people will start to have impairment in their language. Sometimes, they repeat, like words. Sometimes they have difficulty finding words. So any of that, like can occur. Now, what does it entail to diagnose dementia? Again, as I mentioned prior, there should be, like deficits in cognition, and a deficit in any of those domains that would occur for a gradual period of, like a month or years, can occur in dementia. So typically, patients can have impairment in memory, in language. They will have difficulty doing or executing purposeful movements. So what does that mean? So let's say, something as, like paying a bill, or, like sending a check, they might have difficulty, writing down, the right amount of money, or have difficulty, like mailing a check. They may mail it to the wrong, like recipient, so on and so forth. Okay. Patients can have difficulty, recognizing familiar object. So that is typical. Let's say, you have someone who is demented and they want to brush, like their hair, so they can use, like a toothbrush, actually, like to brush their hair. Okay, so I have difficulty recognizing, the toothbrush as a toothbrush, and they think it's a comb. Okay, problem with visual spatial functioning, and that is related to, to their ability to, like to estimate, like distances, and that, this function can be very apparent with when people drive, when demented people drive, and we'll talk about that in a minute. Okay. In addition, poor self-control, can occur. I talked about, the UNM professor who is, like peeing in public. Okay, so how do we diagnose dementia? So there's no particular, test or battery, that we use to diagnose it, and unfortunately, there's not a lab test. So what we rely on the diagnosis is with basically interviewing the patient and doing some cognitive testing, and getting labs, and sometimes, like brain imaging is, is warranted. All of these, things can aid us with the diagnosis. So the diagnosis of dementia remains to be a clinical one. Okay, so there's no lab test to diagnose it. Okay, so on the left-hand side, we have a cross-section of a healthy brain, and on the right-hand side, we see a brain with advanced Alzheimer's disease. So we see, like how the brain is, is all shrunk, and there's a lot of basically, like curvatures, that are very apparent, and lots of holes. Okay, so that is, a cross-section of a brain with advanced Alzheimer's. Now, living with dementia is extremely difficult, as you can all, imagine. So people can, start getting lost in familiar places while driving, or walking. They might not be able to recognize, familiar faces. That usually start happening with acquaintances, and then as dementia progresses, patients might have, or people might have, difficulty recognizing family members. Wandering. That is never normal, and we can discuss, like that, but I'm pretty sure that you have some experience, like with that, like in law enforcement, getting calls and, with reports of, like missing individuals with dementia. Confusion can definitely occur. People might not be, like oriented to place, and they might just, like know their names, and in advanced cases, they do not able to actually tell their names. Urinary incontinence, and can definitely occur, and basically precipitate, like infections, pain, or many demented patients, like have comorbid, like pain problems, and due to the severity of dementia, they will not be able to, like express, their pain, just like with infants or toddlers who have decreased ability to express themselves. So what do? They act out. Okay, and you can see, like similar behaviors in patients with dementia that is severe.
Dr. Khafja?
And feeding problem. Yes, sir?
Hi, it's Dr. Burad. I had a question about how early you generally see urinary incontinence and feeding problems.
So typically, urinary incontinence and feeding problems do occur in moderate to advanced, like stages. That typically happens, but that does not mean, that you can't have, like these symptoms, like early on. But typically, it's it's more of an advanced cases.
Can I ask a question? What about psychosis? Do they ever get like some kind of almost psychotic thoughts and ideas, and what would that fall under?
Absolutely. So we're getting to that. I think that is in the next slide. No, that's a great question. Yeah. I just want to reiterate one important thing about, feeding problems. So that can basically, like precipitate or cause, difficulty, like swallowing, and can, like ultimately cause, aspiration pneumonias and infection. So we often, for example, on the jury unit, like order swallow studies in order to, like assess the ability of, like patients to swallow, like food. Many of the patients have difficulty swallowing, like solid food, and then they would recommend, kind of like a soft mechanical diet or even fluids sometimes. Now, what are the most common, behavioral and psychological manifestations of dementia? Of course, like depression and anxiety can occur. Anxiety is, is a very common one. Any thoughts about what kind of anxiety patients with dementia can exhibit?
Like anger, sometimes frustration.
So anger, absolutely. So anger, frustration, they are confused, they are frustrated about that, they, want to look for, like objects, that they kind of actually, like left around and, and they're unable to find it. So they get anxious, and irritable. Okay. Delusions and hallucinations is a very common one, specifically and again in moderate to advanced stages. And the most common delusion of dementia is? What's the most common delusion of dementia?
Stealing things. Some people stealing or... Right,
so very good. So typically delusions of paranoia are very common, and delusion of theft, okay, which is like, it's a very typical, like example, okay? So grandma or, grandpa is basically accusing family members of, of stealing their money. Unfortunately, that often occurs, okay? But still, it is a very common delusion. So we would need, as healthcare providers and, to try to differentiate or suss out, like what is real and what is unreal. And sometimes, that is extremely difficult. Hallucinations are also, like very, very typical, both auditory and visual hallucinations. Patients with dementia can basically hear voices of people who are not there. Or believe, that people are coming in, like to the house and, like telling them stuff. So that can definitely occur, specifically in the moderate to severe stages. Changes in appetite can also happen. As dementia progresses, it becomes difficult for people to be able to taste food. Okay, so that gets impaired. So with decreased ability, like to taste food, okay, that decreases, the appetite, and that can cause, like ultimately, like malnourishment.
Dr. Khafja, is the
Yes.
decreased ability to taste food something specific to dementia? Is it something that we see in general as people get much older?
So it's not necessarily, like specific with dementia. You can see a variant of that with, like with older age, but that is more pronounced with, with patients with dementia. Having, like decreased ability, basically decreased ability to taste in older individuals might raise the flag for some, like cognitive assessment, but that does not mean, that someone has dementia if they have decreased ability, like to taste. But it would definitely, like warrant, more thorough, like cognitive testing when patients, present as such. Okay. So dementia care can be, again, is very difficult on the individual, suffering from the disease, but it's also, in my opinion, more difficult on, on the caregivers. Okay. So patients with dementia, they would typically, need 24-hour care and supervision. They would need help with their activities of daily living, a lot of things, that we take, like for granted. But then they would need to have, assistance with eating, with bathing, with even, like dressing. Safety is an important, like aspect, keeping dangerous, chemicals, tools, and even sharp knives, from their access. Discussing, like bed and bathroom, like safety. And removing, locks from, like bathrooms and bedrooms, and making sure, that lowering the hot temperature to 120 Fahrenheit or, or less. Because again, these patients have decreased ability to basically also to, like sensation, and they might have, like burns without their ability to feel, like or sense, a temperature. Okay. So what are the things, that we can do to reduce risk of dementia? So just want to let you know that up until now, there are medications that are FDA approved to possibly basically not improve, like dementia per se, but help with the behavioral disturbances of, like of dementia. But there's no, like FDA-approved medication as of yet that would treat the disease. So we always emphasize, regular exercise, Mediterranean diet, doing, intellectually stimulating, like exercises, such as, Sudoku, for example. Patients are, people are interested in that. Maintaining and controlling, cholesterol and high blood pressure and diabetes. That's extremely important because any of those, can also cause, a certain type of dementia called vascular dementia. So it would be important for people to have all of those, like under control. And there are some studies suggesting that vitamin E and B supplementation can help reduce, the risk. Again, all of these things, studies have shown that they can reduce the risk, but they are not, they are not, like definite or absolute treatments. So going back to caregivers who are helping out with, with people with dementia. As I mentioned, it's a very difficult job. It would be extremely important to basically assess for, like for depression and anxiety in that, in that patient population. So you often go to someone's home or you bring these patients with clinics. The patient is very demented, they're unaware what's going on. And you typically see the family member is very depressed, very anxious, agitated, like irritable. And that, like if that is not, treated, sometimes, can cause basically patients, like to be, like to be harmed, like by their caregivers, like due to their, to the frustration. So it would be extremely important to recognize, these early signs and symptoms of, depression or caregiver burnout, and be able to educate, the family members about that. Okay, for many of the family members, we can recommend, like support groups, individual counseling, or even, like group therapy.
Are there support groups in the Albuquerque area for that? So
there are support groups in the Albuquerque area. So we have the Alzheimer's, like association. We have a chapter here in Albuquerque, in the northeast side of town. So it's a great resource. And also at at the mental health center, seniors clinic, we have one of the nurses, like over there that run groups for, like for caregivers.
Through UNM.
Through UNM. Okay, so I'd like to discuss this case. So we have a neighbor who calls 911 for a wellness check on an 81-year-old who's living alone. So you go in there as, like law enforcement, and, the house smells of urine, there are cat feces on the floor. You talk to the woman. I mean, you have a look at the woman. She appears to be, like physically well. She's alert and oriented to person and place. However, she, you get concerned because of the kind of the presentation of the house, and you suggest, that the patient is get transported to the ER for for a well-being check, and she refuses. So how would you approach like this individual? Do you say, okay, that's okay, I'll come back later? Or do you, quote unquote, try to force her or convince her to come to the ER? How do you make that determination? And again, there's no right or wrong answer here. I'm just trying basically to, like elicit your responses and see how we think about that. Any volunteers?
Hold on, if no one else is there anyone on the network that wants to? No. Detective Savage with APD. I think I would start with trying to collect some collateral information, like as far as family support, so that I could get kind of a baseline. Is this something that's normal to her? Or has the patient declined like over the last 6 months? Is it slowly getting to this point? Try to figure out if she has been to the hospital before, if they've diagnosed her with anything. And then just kind of work on trying to convince her that it's probably for her best interest that she go to try to get help. And that might be, I think that's going to be tricky, but I think if you get family support there to say, yeah, Grandma, you have been kind of declining lately and we want you there so you can take care of your cats, I think that's the approach I would take. I don't think you have enough to force her there, but I think you might be able to talk her into it. And if you can't that time, then it's not just that and over. I think you need to do follow-up and try to, because then you'll have your own baseline of when you met her and over the weeks if she's declining. I think if you can articulate her decline a little bit more, you might be able to eventually take her against her will.
Absolutely. So I think that is a great approach. What we're facing here is basically, like patient autonomy, right? Like versus safety. Okay. So we are all respectful of, of patients or persons, like ability to make decision for him or herself. Okay. But at the same time, like being in, I guess in law enforcement and, like in medicine, we are here, like to help, individuals and, and make sure, that they are, safe. And sometimes, both of those, like principles, they get at odds, like with each other. Okay, you have someone there, like who does not want, like to come into the, to the or to the hospital for a welfare check, but you're still concerned about them. And then, like, what do you do? So I think what you provided in terms of a thought process or a way to think about it is very appropriate. It would be extremely important to basically, get collateral information, maybe contact a family member and see if there's an acute thing or a chronic issue, and then try to convince, like the patient to basically to seek more, like help or assistance. And if that is not possible, like at that particular period of time, then to try to arrange, like for further follow-up, like in the near future. So let me go ahead and mention.
Sorry to interrupt you. Sergeant Pullen wrote about about adult protective services, maybe making a referral to them if it's a lower level one.
Absolutely. So that is, like an integral part of the follow-up. Thank you for that comment. That is extremely important, and I missed to mention it. So we try to, like involve, like adult protective services, like in these cases where we suspect, that there is, like neglect or abuse, that is going on. Thank you for that. Okay. So these 4 ethical principles, remain to be the main principles that would guide, like our basically care when we deal with patients, and that has nothing necessarily to do with dementia per se. So that pertains to all patients. Okay, so it's important for us as healthcare providers to respect patients' autonomy. Okay, so freedom or ability to make a choice. Okay, we need to do good, right? So beneficence. Okay, we need to help them out, do no harm, and do justice or whatever we think is, is fair for the patient. Okay, so sometimes, again, as I mentioned, these principles, come at odds, like against each other. Okay, such as the principle of, like freedom versus, like doing good. Okay. So, and what does pertain in your opinion if the patient is able to make decisions regarding his or her care? So the principle of autonomy, okay, is the one, you know, that would dominate, you know, like over here, okay? So if an individual, you know, comes and tell you, you know, I know that I'm sick, but I do not want to go to the hospital for a valid reason, you know, that they have, you know, that their autonomy need to be respected, okay? However, that only pertains when individuals have the ability to make rational decisions, okay? So let's say, you know, you have an elderly demented person who's telling you that they do not want to come, he or she does not want to come into the hospital because, you know, there is basically aliens, you know, like are going to meet her at the hospital in order to kidnap her, okay? And that's why she does not want to go over there, okay? So that is, you know, an overt delusion, okay? That, in my opinion, does not mean that's irrational and would not mean, you know, that the patient is able to make a decision on his or her behalf, okay? So it's really important for us to try to differentiate and figure out if, you know, if the patient or the person is able to make decisions on his or her own behalf. And sometimes if patients are unable to do that, you know, they have a medical power of attorneys or family members who would be able to make, you know, like decisions on their behalf. So what does get involved in determining, you know, like decisional capacity? So how would we determine if someone is able to make his or her own decisions? Okay, so it's extremely important to be able to communicate a choice as a person, whether that is, you know, like verbal or written. Okay, be able to understand the nature and the consequence of that choice. That if I do not come into the hospital, that, you know, for example, you know, that my blood pressure is going to be very high and then I'm going to possibly, you know, like suffer a stroke, okay? They would be able to understand that information and make the necessary choice. And their reasoning should be consistent with choices, you know, that they've made in the, you know, like in the past, right? So if you know someone who is, you know, very health conscious and, you know, they always, you know, like went to the doctors to take care of things, and, you know, they always had, you know, for example, you know, their blood pressure, you know, like checked, and all of a sudden, you know, like they don't care, you know, they don't want to go to the doctor, you know, they even deny, you know, that they have, you know, like blood pressure problems, okay, then that might, you know, like raise, you know, like a red flag. Okay.
Can I ask a quick question on that? What if they're in care, you've taken them to the hospital, and they don't want to comply, they don't want to eat, they don't want to take meds, they don't want to, where does that, when you start talking about that ethical dilemma, how does the hospital look at that?
So that's a great question. So we assess, you know, like these cases on obviously on individual basis, okay? We try to determine, you know, like again, what's the reason of the, you know, like for the refusal. Sometimes, you know, like patients who are extremely, you know, like depressed, you know, like they get catatonic and, you know, and very paranoid, you know, they refuse to eat or drink and they just sit in bed, you know, like all day, okay? So with these individuals, you know, if we determine that they do not have capacity to consent to treatment, we try to get them, you know, like treatment guardian, you know, like in court, and try to get them treatment, you know, against their will or until, you know, they get better and be able to make, you know, like a decision either or.
Okay. Thank you.
Thanks. Law enforcement and dementia, again, I'm pretty certain that you encounter, you know, many individuals who suffer from dementia or cognitive impairment. And these guidelines I was able to get from the Alzheimer's Association. There's a chapter that is dedicated for law enforcement. I don't know if any of you have seen that before.
That's great.
Yeah, it's really helpful. It's there on the, you know, on the website. Typically, you know, law enforcement deal with, you know, like erratic driving, you know, motor vehicle accidents, right? False reports, you know, patients even on the unit, they call 911 while they are on the geri psych unit, right? Falsely accusing, like staff of, of kidnapping or of, or abuse, even in psych emergency services, that often, occur. Indecent exposure, right? You have a 70-year-old, like walking, like naked on the street. Okay, so that is never normal. And we, right.
Sometimes.
Yeah.
I'm almost there. I'm almost there,
Right.
so I don't want to say.
So, right, we typically look for, again, for a, like a medical, like etiology, is the patient, again, physically sick, they have an infection, are they high on drugs, or is there, like a dementia going on? Shoplifting, that often can also occur. And again, patients with dementia are at increased risk of suicide, and they are also able to, harm, like others, like due to, like confusion and fear. So sometimes, they, lash out consciously or unconsciously or subconsciously in order to protect, like themselves. I remember a patient who was admitted to the geri psych unit a few years ago, was basically in a nursing home, and he had, moderate dementia. So the nurse came in to pass meds, and I think he got scared or something. So he took a TV set and he threw the TV set, like on the nurse, sustaining, like pretty serious injury on the behalf of the nurse. Okay, so that landed him an admission to the geri psych unit. Okay, so sometimes, these behavioral disturbances, like do occur, and they are very severe. Okay, just want to discuss a little bit driving patients with dementia. So dementia increases the risk of crashing. Okay, so that is, that is a fact. Okay, it's one of the most contentious issues, that we typically deal with, like in healthcare. Okay, many of the patients, one of the most common reasons of patients, like storming out of the office is, like when you tell them, that it's not recommended for them to be, like to be driving. Okay, it's like depriving them of their, basically, of their freedom, right? So it's extremely contentious. Many of the patients, like do not understand that the illness is, is getting worse, and that is again part of the illness because, their cognition, gets impaired. Road evaluation remains the gold standard for assessing for safety. Okay, so and that is, the MVD is, is responsible for doing that. And few states here in the U.S., like mandate, the physicians to report drivers with dementia, such as, like California. Here in, bless you, here in New Mexico, there's an MVD medical report, like form that is available online. And when we suspect, like impaired driving, and when there's a diagnosis of dementia or seizure disorder, an acute medical issue, and we believe that the patient is not fit to drive, then we, in my opinion, it's our, like moral and ethical responsibility, like to fill out, like that form and, like inform the MVD. We mail it to the MVD in Santa Fe. They contact the patient, and then they basically take further steps to assess them for, for ability to drive. And I have, a few patients who are like their driver's license actually was revoked because of them being unable to drive, like in a safe manner.
I have a question. Matt Smith, APD. Mm-hmm. Do you have to let your patients know you're doing that?
You don't have to, but I, for sake of transparency, and to be clear with the patient, I do that. Okay, I would rather be the bad guy rather than, like another family member informing the patient and being the bad guy.
Would you ever just take away their keys?
That's a very good. Many family members, like do that. Okay.
Not as you as a doctor saying, I'm a doctor, I'm taking your keys.
No, I wish I can do that, but I don't have magical powers.
Magical powers?
Right.
Apparently, Niels has magical powers.
Yeah, except for Dr. Rosenbaum. Yeah. So many family members, like go ahead and do that. They take, like keys away, or they take, the car battery away, right?
Huh.
But
hide the car.
Right. So I believe it's, again, I have a low threshold about, like reporting, and I tell the patient that I'm not making the decision to, to take away your driver's license. I'm just doing my job in terms of, like reporting you, and it would be really up to the MVD, to make that decision.
Yeah.
I know. Yeah. Okay. So a few tips, that I felt were, like helpful in terms of, interacting with people who might suffer from cognitive impairment. So as we all know, it's extremely important to identify yourself as a law enforcement, like officer. Explain what would be the reason of, of you approaching, the individual. Maintaining good eye contact is very important. Speaking slowly in non-threatening manner. Low-pitch voice, is very helpful to calm down patients with, with cognitive impairment or disorder. Sometimes, they have difficulty actually hearing high-pitched voices. Okay, and try to use, like short, like simple words. Asking yes or no questions can, again, help try to identify, like the problem rather than, like asking a very open-ended question that can, further, like confuse the person. Patients with dementia have difficulty multitasking, so asking one question at a time is extremely important, and giving them, like plenty of plenty of time to respond. Because of impaired hearing, they can also have, like difficulty teasing out, like multiple voices. So it's extremely important to talk to them in a calm environment where there's not much of an excessive stimuli. Like instead of talking to them, like out in the backyard when it's, it might be, like noisy, maybe just going inside the house and talking to them might be helpful when it's less noisy. Reducing radio volume and avoid use of sirens. Okay. Try to avoid, restraining patients. And this is an approach, that we also use in psych emergency services and also on the units. So we always try to take, the least restrictive, like approach. So we typically, spend a lot of time trying to verbally de-escalate, these patients prior to offering medications or even restraining them. As a matter of fact, we got away with restraints on the unit, on the geriatric unit, about a few years ago. Because all studies have shown, that they are, can be very harmful and would increase, like mortality.
You don't use them at all?
We don't use them unless, in very, very, unusual, circumstances. Yes, but we don't have them on the unit. And of course, avoiding confrontation is extremely important, especially if someone is very confused.